Perfect. So guys, thanks. My potential conflicts of interest. I show you 200 plus patients real world impact, the Carillon IMI therapy in routine care. Let's have a look. We have a very good patient case development over the time, and 99% of all attempted were finally treated. We always compared the baseline versus a 3-month follow-up. The study design was retrospective, non-randomized, and it's the largest single-center study till now. And in our registry of consecutive Carillon cases, you can see that we mostly treat women, female patients, 68%. The mean age was 83. The mean Euroscore 2 was 8.4, and the ejection fraction 43. Very interesting, the trinity of atrial fibrillation, severe diastolic dysfunction, and functional MR was the common denominator, or it seems to be. Procedural information is quite a sensation. If you just have a look at 0.0% intervention-related death rate and how aging and fragile the patients really were, it's perfectly worked out. Nobody gets hurt. In 1%, we had to perform a pericardial drain because of an effusion. In the 9%, we were forced to treat the circumflex artery because of compression. We are quite open-minded, we do it, and we had tremendous results. I'll show you later. The learning curves, yeah, we talked about it. It's quite impressive how fast and how good you can get over the years. Intervention time is in the mean 80 minutes in our hospital. Radiation time 20.8, and the contrast agent expenditure was around about 100 millimeters. The inpatient stays were quite stable. It's a quite cut thing in Germany. We were forced to hold patients for several days. The outcome analysis shows that we can successfully shrink down the diameters. The mitral valve ring in the apical 4-chamber view was reduced in 20% and 18% on the 2-chamber view. And the MR severity, quite hopeful. We re-established the MR1 in 67% and in 33% MR grade 2. Vena contracta was lowered of 40%, and the pulmonary lung pressure 20% lower than in the baseline values. The NYHA stadium was perfect. Our patient loved the result, and in 98%, we were able to re-establish NYHA 1 or 2 in combination to their heart medication. Quite successful results here. BNP levels quite spreaded, as you can see on the image on the right side, but 47% reduction in 3 months, quite a sensation. It's always a multifactorial thing, we talked about it, but it's a great result in the end. And the most common asked question was, when we've been around with our data, in how many patients you were forced to treat with MTR, and 16% we did both. It worked out fine. We made a different paper. It's still in progress, and tremendous results. And outcome overview. You can really see that you can change all measurable items you want. And one thing, hypothetically, in our database, we found out that there's a nice side effect, a co-reaction of the E2E prime levels, a measure item in the echocardiography to show the atrial filling pressure, and it was lower in 30%. It was quite, I think, a crucial point here. It's a multi-level approach for our patients, I think. Yeah, but unfortunately, nobody was ever interested in this fact. The other results were quite great. You just saw it. And conclusion, we have a really high success rate with an easy intervention. We have an excellent safety profile. We have a rapid lining curve. We have large improvement in all mechanistic variables. We have high clinical benefits and the ability to combine it with all known therapies till now. And you don't need a TOE. You can do it without general anesthesia. Patients literally can look over your shoulder and you keep the natural valve. Yeah, just that you have a quick overview how we choose our patients. This is a quite nice functional MR passing through in central position, and you see how tethered the leaflets really were. The ring was distended on 46 millimeters, and in every cath lab, you can implant this device. With a reckless pull round circling the MV, you see in the aftermath a nice shadow of the device shining through, and just have a look how the leaflets were free again. Yeah, and in the end, it was treated successfully. So it's easy, it's nice, and it's safe. Thank you.
Thank you for the presentation and all the work you've done. Excellent results, really impressive results. And I wonder, how come this easy procedure, it's a really easy procedure, so user-friendly, a lot of people will be able to do it. So I think the secret is to find the population, the patients that are going to benefit most from this procedure. I personally had experience with a Monarch device, which was another device that was abandoned by Edwards many years ago for various reasons. I think that the secret is exactly this, to find the population. So do you think that patients with proportionate FMR would be a good substrate for this therapy?
Yeah, good question. I think that every patient with a real giant left atrium and with big problems in atrial fillings, you see how distant the leaflets are from each other, and the functional MR is quite easy to approach. And these patients we treat if the FMR is quite moderate. The biggest one we always try to treat with a combination of both M-tier and IMA. But in the end, I think if the patient is fragile, we choose IMA because nobody gets hurt. It's easy. It's an easy intervention without any problems.
Perfect. Any questions from the audience? Yes.
Thank you very much for an excellent presentation. You presented your series with a patient with 60% approximately coronary artery disease. So you are presenting to us ischemic cardiomyopathy patients with type 1 functional MR with annular dilatation only, or some of them are with type 3B, let's say. So my question is, which is the ideal patient for your method in ischemic cardiomyopathy patient and functional MR? And secondly, I'm a cardiac surgeon. So there is a long-standing debate about how to surgically treat the functional MR. Is it just enough the reduction annuloplasty, or it should be something plus? So there are at least 10 additional procedures, just to mention one, the elevation of papillary muscle, etc. So we have also found that in some patients, by reducing the annulus, we are increasing the depth of the papillary mass. Have you seen that in some patients?
Yeah, we had a lot of patients with a combination of problems, and the atrial FMR is the nicest one to treat, in my opinion, because it's quite easy. You just near the leaflets, and it's closed again, if the FMR is moderate and not massive. But in my opinion, we learn a lot from the past few decades, where heart surgeons, they already made all these experience. They tried to do just a Alfieri stitch. They saw, oh, it's not working right. They did the annuloplasty in combination with the stitch, and it was great. So I think we should take the next step and do both. It's we just working, or it's still we still working on our paper. The combination of both procedures will get tremendous results. So I think we try it with the easiest intervention, and if it's not enough, we do both. That's quite a strategy we use to decide for all patients. And all patients agree in the possibility that we might treat the circumflex artery with an additional stenting or PCI, because it's quite often, if you perform reckless pulling and you don't think about not to annoy the circumflex artery, if you do reckless pulling, you will make a compression. It's quite often because you changed the anatomy. It's an anatomy changing thing. Yeah, and then you have to treat it. So I think this is another key point.
Perfect. Do you think there is a tendency for this device to treat better medial or lateral MRZs towards P3 or P1? Do you think there is any difference between those two origins of MR, or it doesn't make any difference?
We already treated some patients with jets next to a clip in A2, P2 position, and the jets were passing through beside the clips on both sides, and we had great results. But the easiest MR to treat is the central one passing through in A2, P2 position, and you just have to put down, you pull down the posterior wall with when you have a good circle around the mitral valve, and these patients nearly always have a good result.
Thank you, Dr. Priebe. We're all excited here with the EMPOWER trial. We're going to start enrolling patients here in a year 2 after VLAS in Thessaloniki. So we hope this study will give us the final answer as to whether we should expand the use of this therapy for our heart failure / MR patients. Thank you.
Thank you.